So, growth of palliative care in India, it established in mid 1980, the hospice in Mumbai. 1990s, NGOs pioneered palliative care development. The Pain and Palliative Care Society Kozhikode was there, Can Support came up, Network Neighborhood in palliative care developed in Kerala, skewed distribution of care. So, almost 1000 palliative care units in India are there in 16 states by the 2012. It is basically community and NGO based. Why are we lagging behind the schedule? There are very few integrated palliative care systems. Isolated services are there, irregular and unsupported reach is there. It is dependent on donations and there is no financial resource allocation. Limited hospices in relation to population size, limited access to morphine, limited academic activities all over India. Where do we have to work hard? We have to work hard on team making, to start the services with available infrastructure. Again, keep on improving and start making visible changes. Talk to the administration where it is possible, taking your colleagues with you in your mission, and do not forget to take care of the self, because you will be suffering from burnout. How to start? Establish an OPD service in your institution, establish an inpatient or consultation license service in palliative care, arrange for uninterrupted supply of oral morphine in every institute, and initiate advocacy activities within and outside the organization. So, when we are talking about advocacy, Cancer Aid Society since 1987 is involved in advocacy on various aspects, including palliative care across the country. Appoint a palliative care physician at the earliest possible should be the goal of all the hospitals. How can you convince the administration? The positive outcomes may be family meetings, better understanding and diagnosis and prognosis, informed choices, and better, this all leads to better patient and physician relationship. What are the benefits involved? We are involving the patient and the family, we are involving the staff, we are involving the organization, and integration is leading to the benefit for all. What will be the starting point? Education and training, we have to focus on that. Human resources and development, we have to go into knowledge management, and we have to develop knowledgeable networks, and that is what we are trying through NPTEL right now. What do terminally ill patients want? Information on current status and future course of prognosis, honest, complete communication by health care providers, and it has to be done sensitively. Freedom from pain and suffering, reassurance has to be there. Increasing control of life to maximum possible lifestyle modifications, interventions have to be there. Respect, empathy has to be developed, not just sympathy. Easily approachable expert whenever it is desired. And remember, even now many patients are not aware what they are harboring, as the disease is hidden from them. So, what can be done? We have to learn how to break bad news. So, recently there was an incidence where a pancreatic cancer patient came to a private nursing home in terminal stages. Doctor did not disclose the diagnosis to this patient. The family was not disclosing the diagnosis to the patient, and this patient was basically a diabetic patient too. In her last stages, when the family members, she was living alone, she was ordering food through Zomato and Swiggy, enjoying life in spite of having very high sugar. When she was ill, the family members came, they restricted her diet, but since she was not aware that she is suffering from pancreatic cancer, she started asking the attendant, tell them to leave. Leave who? The family members. Why? Because they were disrupting her regular routine. She was enjoying lavish food. However, because of diabetes, the family members were controlling her diet. Finally, she had a miserable death. So, that is a learning story. We have to break the news to the patient at the right time, so that they become cooperative rather than confronting with the families. Now, providing information at patient's pace of acceptance. So, if you break the news suddenly, what happens? The patient may suffer from an heart attack and expire because of that, rather than the disease itself. So, it is an art which needs to be learned. So, you have to provide realistic hope also, empathetically making patient and caregivers feel empowered to take decisions. Involve the families when patient is unable to express desires or decide. Reassure that freedom from pain and suffering would be there. Respect the cultural and familial beliefs and traditions, and provide professional counseling if it is required. So, what procedure should we adopt? Recognize the dying process. It has to be honest, accurate, and early disclosure of the prognosis to the family. Proper communication among the physicians, supporting staff, and patient's family has to be there. There has to be consensus among all the caregivers, and there has to be transparency and accountability through documentation. Initiation of institutional supportive care protocol should be done. Neither hasten or postpone death with good symptom control should be the ultimate goal. Create a system where you want to die yourself. The reality is that most of us end our lives in an ICU, shelling out lakhs of rupees. Do we desire it at all? Certainly not. We do not beat the reaper by living longer, we beat the reaper by living well. Last lecture of his life, really achieving your dreams, childhood dreams, was on September 8th, 2007. This is Professor Randy Pausch, Carnegie Mellon University. He died on July 25th, 2008 at the age of 47 because of pancreatic cancer. Best treatment available is 100% relief. So, humanity, it is the wonder drug. Medical science is incomplete if we will not teach dying with dignity, as it is a part of life. Thank you.